other things to mention as a bit of sort of housekeeping, we are putting together this directory in conjunction with the ALS Association of outpatient palliative care programs that care for people with ALS. So if your program falls in that category and you'd like to be featured in the directory, that would be great. Please do complete a survey. Thank you, Gail. Here's a QR code to complete the survey. And then, Gail, do you mind pasting the link in the chat too, in case it's easier for people to click on it? You can click on the link right now and should only take a couple minutes to complete. And then second survey, sorry, we're trying to kill you with surveys apparently, but we are also just interested in your feedback on this palliative care for ALS working group. Turns out we've been at this for 2 years now, having launched 2 years ago at INPCS, although I know that there were iterations of the group for much longer before that. But we'd love to revisit sort of what have we been doing through these monthly meetings and between meetings. Are we focusing on what you're hoping we'd focus on? Are there other things we'd like to do together? So please give us your honest feedback. We'd greatly appreciate that. So there's that QR code. Thank you, Gail. And do you mind pasting the link in the chat for that one as well? And you feel free to just complete that during this meeting too, if you don't mind. Third, Jessica Mabe from the International Alliance of ALS and Motor Neuron Disease Associations was hoping we could let you all know that they're trying to reach people living with ALS and their caregivers or blood relatives to ask them about a variety of different topics. So if you have patients who might be willing to complete a survey for them, that would be great. And we will circulate that information. I'm not going to put it in the chat for fear of overwhelming you, but it'll be a separate email that they're hoping to reach people living with the illness and care partners and get their perspectives on their needs and their care. And yeah, Kathy, no worries. Survey links are coming from Gail momentarily. Any questions about any of that? If not, I'll hand it right over to Cara, who's going to talk with us about a really interesting case of neuropathic pain in ALS. And thank you, Cara, for being willing to discuss this case. It's sure to be relevant and interesting for many of us. So I'll hand it over to you. Thank you. Thank you.
Cool. Absolutely. Thanks for inviting me. And can everyone see my screen okay? All right, cool. So this talk was born out of some conversations over email where I reached out to probably many of the people on this list in a kind of old email thread asking, does anyone have any ideas about this patient? So I can tell you sort of where it stands, and we'll talk a little bit about neuropathic pain and ALS, but my hope is that this is a discussion, and so feel free to ask any questions or share any thoughts along the way. And I'm a neurologist and a palliative care doc at UCLA, and part of my role is I work in the multidisciplinary clinic for ALS patients. So this is a 58-year-old man with limb onset ALS, and I met him in the multidisciplinary clinic, and he was complaining of severe neuropathic pain. So he initially had a diagnosis of PLS in 2019, but eventually progressed further and received a diagnosis of ALS in 2022. And he doesn't have much past medical history, but he does have a history of substance abuse. So had a remote history of alcohol abuse, had been active in AA, no drinking for over 30 years. And then in 2008 had gone to have a dental procedure, got some oxycodone, and then used heavily, was buying kind of on the street for about 6 months. And sorry, that's a PowerPoint presentation line left in there. But so some substance abuse history for him.
But only opiates or oral opiates or?
Yeah, oral opiates, alcohol, and then he had also used some actually crack cocaine in his early 20s.
Okay.
So he described his neuropathic pain as like a lighter on his skin. And it was sort of in non-dermatomal patches over his face, arm, and legs. And just absolutely excruciating, intolerable. And he was sort of visibly in agony in the clinic. He also complained of severe fatigue and depression. And in talking about his emotional state, he shared feelings of grief, sort of loss of control, shame, a lot about his changing identity with his self and family. And he even shared that he had some suicidal ideas, but dismissed this due to the pain it would cause his family. And he identified that basically his pain was so severe, his sort of motor impact from ALS was quite minor, but the pain was so severe that if he didn't have children, he thought he might end his life. Uh, so he was under the impression that this may be helped by baclofen. So he had a baclofen intrathecal pump and was on very high doses of that. And then he was using kind of massive amounts of oral baclofen, up to 120 milligrams total daily dose, on top of very high doses of intrathecal baclofen. He was on gabapentin 300 BID. He was taking a lot of Advil, 1400 milligrams, and 2 Advil PM at night, melatonin at night, Valium 5 to 15 milligrams at night, and Norco 1 to 2 tabs nightly. So with all of this, he felt none of it helped, except very clearly the Norco helped him. And he was able to sort of interact with his children after they came home from school. It gave him just enough relief that he really could sort of uh, have some moments of presence with them. But he really didn't want to be taking the Norco. He felt hungover from the opiate the following day, and he wanted to get off of it. And he was using the sleep aids because the pain was so severe that he couldn't sleep. So he was trying to kind of knock himself out. So in general, he's a well-appearing middle-aged man, but clearly in a lot of pain. Normal mental status, some fasciculations over his tongue. He had very mildly increased tone, really just in the right upper extremity, essentially. Otherwise, no spasticity on exam. He had a little bit of weakness, primarily the left deltoid, his finger flexors, extensors and interossei, and a little bit of hip flexion weakness. He had brisk reflexes, and he had a sort of patchy sensory examination, some areas hyperalgesia, and some mild relative reduction in sensation to pinprick, but intact vibration and proprioception. No clear ataxia, and he had a slowed gait without spasticity. So workup we did a pretty thorough serum workup, and some inspired by some comments from the collective in email. So thank you for that. And the one thing that came up positive was that he had positive cryoglobulins. I got very excited, but his cryocrit was minimal. I had him see rheumatology, and they said this is not clinically relevant. Otherwise, everything's been normal in his serum studies. And sorry, I did this late last night, but his prior EMG at initial diagnosis showed changes consistent with motor neuron disease. And we did repeat an EMG, and it showed this length dependent large fibrosensory motor axonal polyneuropathy. And then he had unremarkable MRIs of the neuraxis at time of diagnosis. So looking into the literature a bit, and certainly from clinical experience that I've had, and likely all of you as well, feel that pain is a common and under-recognized symptom of ALS. And as a neurology resident, I was taught it's not a painful disease, and we certainly know that's not the case, but it's usually due to spasticity, immobility, musculoskeletal pain. And a minority of patients report neuropathic pain, so burning, shooting, electric type pain. Certainly his description of a lighter on the skin is a perfect example of neuropathic pain, and that it's really superficial. So what causes this? So there is evidence of small fiber neuropathy or sensory nerve involvement in ALS. When skin biopsy studies do show changes that are consistent with sort of small fiber neuropathy, and it's likely not clinically sort of relevant for most people. And there also may be there's sort of more theoretically altered central pain processing associated with ALS, and we know that ALS certainly has sort of cortical and central component to it as well. And then immobility and muscle atrophy may also cause, nerve entrapment, compression, and sort of contribute to sensory symptoms in that way. There are no studies on, oops, I'm receiving some chats. Okay. Alcohol use is an interesting idea. And what does he do now to address the pain he experiences it? Okay, I will get to those. Thank you guys. In terms of his alcohol use, the alcohol use was remote. So he hasn't used in more than 30 years. So I haven't seen cases of it emerging so late, but I don't know if others know if that's a possibility. And so I will tell you kind of what we started moving towards now to address the pain. And that initial regimen, yes, he was using a lot of Advil, a lot of baclofen as kind of his ways to initially self-medicate, as well as the Norco. And the IT pump was placed by a PM&R pain doc at another institution. So there are no studies on neuropathic pain management in ALS specifically. So what most people do is use our, typical pain recs for neuropathic pain. So gabapentinoids, TCAs, SNRIs, and then opiates if very severe. So how I approached our patients. So I'll tell you that this has been a collaborative effort. I initially started with him. I ended up also referring him to a palliative psychiatrist colleague who's been working on symptom management as well. And he also he goes to 2 multidisciplinary neuropalliative clinics in Los Angeles. So he also sees Jessica Besbris, who is a neuropalliative doc at Cedars. And so we've gotten to collaborate and talk through ideas for him too. So I'll tell you that how I first approached him was actually started off with methadone because he was in excruciating pain and it was clearly had an opiate responsive component. So started that at a low dose, and I basically scheduled him for weekly visits because I was very, very concerned about his level of pain, his amount of emotional distress, and his risk with medication use, his history of substance abuse, and kind of how much medication he was taking sort of on his own. I wanted to be sure that we were being safe with this. Started weaning him off the oral baclofen because he had significant sedation, nausea, and it was at times he was adding on tons more oral baclofen and believing it was the methadone, and so it was a little bit tricky to kind of get him through that period. We reduced the Advil total daily dose. The Advil doesn't seem to really make an impact on the pain. Pulled off the Advil PM. We initiated Adderall for fatigue. Then that was switched to Concerta with some data that Adderall is more implicated than other stimulants in spasticity pain, and perhaps could be aggravating for his neuropathic pain, but the Concerta didn't give the benefit for kind of his energy issues, so he wanted to switch back to the Adderall. And significantly reduce the Valium and the Norco usage. So he was taking, up to 3 Norco a night, but feeling very hungover, really wanting to get off of it. And this has given us some days, up to 4 or 5 days in a row with him not using Norco, and then he'll use 1 to 2 pills, and the Valium is sort of capped at 5 milligrams nightly. I then initiated duloxetine, and the number needed to treat for duloxetine and neuropathic pain is 9. So and I have never seen someone say, wow, that made a remarkable difference in my pain. So which is why I kind of wanted to start at a heavier hitter. And he had an incredible response to duloxetine. So he had not been able to work in 40 days due to the pain. And about a week into starting 30 milligrams of duloxetine, he was actually back at work. So he had a really positive response. The reason the methadone dose, by the way, is low is because he felt that it was sedating and kind of harder to get up higher on that dose. So he had actually he's had a couple of months of relative improvement, improved symptoms of the duloxetine, kind of slowly increasing that dose. But last week he's starting to feel like the symptoms are kind of coming back. So there may be some sort of flare or episodic component to whatever is kind of underlying this pain process for him. And he continues on the gabapentin. Okay, so as I mentioned, he's returned to work. There are ongoing ups and downs in symptom intensity, and many sort of directions I see as possibilities for his medication management that you could imagine here. So he's on very low dose of gabapentin, which we could certainly alter. As he's removed more of the other sedating medications, potentially increase the methadone. So those are kind of two possible avenues for him that I'm thinking about. And then the other thing that's gone on is that it's gotten very clear over time how much the kind of emotional and existential aspects of his experience are playing into his pain, and are playing into kind of his overall distress. So we've had, some visits where he has worried that the level of pain he's experiencing is a sign that he's dying and he must say goodbye to his children. And when I'm able to talk him down, that actually, like, he is in pain, but he is physically safe. The pain is significantly dissipated and he is sort of feeling a lot better. So I'm doing a lot of also exploration of these topics. And because he had such mild motor symptoms for years, he was able to continue to work. He's an extremely successful furniture salesman, brings in over 6 figures monthly, doing that, was able to continue doing that, felt like I don't really have anything wrong. And his wife sort of mourned the diagnosis of ALS really right when he got it. And he said he was able to not do that. But this pain syndrome has really, totally changed his life in a way that the ALS diagnosis hadn't. And so he's really in that grief space of feeling like he now is needing to think about legacy work for his children and really sort of coming to terms with the whole diagnostic picture. And let me see, I see some chats. Aha. Duloxetine hit or miss? Yes, yes. Did he develop tolerance to the sleepiness with methadone? That's a good question. It seems like he has. Yeah, that has improved. HIV and hepatitis were both negative. And so I haven't increased the gabapentin only because I went to these other two kind of options first, the methadone and then the SNRI, and was worried about sedation for him. He is totally unaware of if gabapentin is particularly sedating, if it's helpful for him at all. He's just not able to tell me. But I think that increasing the gabapentin is a good next step for him. Yeah. And buprenorphine, yes. So this was the same thought that Jessica Besbris had, is if we know he's opiate responsive, but he needs just a super low dose, he might be a great person for a bup. The duloxetine, yeah. So Ombre and I had the same thought that the other reason why I'm suspicious that the emotional component is a big part of it is because he had such success with duloxetine. Reiki or acupuncture. That's a really good thought. We haven't broached that. That's a good thought. He's got this extremely dynamic, commanding personality. He uses a ton of cuss words, and he's like, it would be funny to see him in that kind of setting. I wonder if he'd be open to it though. He's be cool. Yeah, yes. So, this is a great thought, Kwame. We hadn't thought at all about sodium channel blockers and anti-seizure medications. I love that idea. Um, and we did talk about scrambler therapy. Um, and that is kind of on the table and something we hadn't pursued yet. Suzetrigine, I'm not familiar with.
It's a newer med, like one of the newest pain meds to come out, I think earlier this year. They did it for
Ah,
like smaller surgeries, like bunionectomy or like
bunionectomy.
an abdominoplasty, like
Yes,
outpatientish surgeries.
got it.
Only up to 14 days though. So yeah, I think it's interesting for like non post-operative pain. Like in our palliative care population, folks will likely need it for months, if not years. What that looks like. I'm sure there will be lots at AHPM if people are using it in the palliative care population. Um, there was something else. Speaking of AHPM, if this could be an interesting case for it. I know the call
Hmm.
for abstracts is coming out later on this month for early career cases. If that's
Hmm.
still you, I don't know, you might be slightly aging out of the early career if you were to mentor someone. Um, just talking, I think, about pain and ALS, because you're right. We're all like, oh, it's a painless disease, et cetera, et cetera. So there's like some of these references I think are interesting, whether you see
Mhm.
a lot of ALS or not.
Okay, cool. Claudia, thanks for that. And no, he has not had a skin biopsy. Um, but I would be curious to ask the group, like, do you think that that might be, oops, do you think that that might be helpful for him?
I think the skin biopsy could help confirm if the pain is peripheral and if he has a small fiber neuropathy that's causing the pain as opposed to a central etiology.
Mhm. Okay, cool.
And if he had a small fiber neuropathy, then IVIG might be considered. Is that right? Or not necessarily?
That's a really fraught question in
Yeah,
neuromuscular world.
not necessarily, but you might use more of the um, classic neuropathic pain meds.
Mhm. Fair
Yeah, the
enough. And it seems
initial
like people
wording.
are enthusiastic about the neuropathic pain meds in general. Like maybe one thing to comment on is I find that I often have to combine them and push the doses up like you have for the duloxetine. So that makes sense. But sometimes I feel like people need 2 or 3 neuropathic pain meds, which is a lot of meds with potential side effects, but um, can be more helpful in combination. And then I was interested in people's thoughts about buprenorphine, if you don't mind me asking. Like, I am using Butrans patches in particular a lot lately when I'm worried about, you know, the side effects and consequences of long-term opioid use, particularly in someone with substance use disorder history. So I might be tempted to start with a Butrans patch, but then I also haven't found much benefit often. And I know it's a lower dose form of buprenorphine, but I just wonder if other people are also using Butrans patches a lot, how high you push the dose. Sometimes I'll find more benefit at like a 40 microgram per hour dose, even though that's higher than the FDA recommendation. Or if you feel like, you know, it's not surprising to you at all that the low dose Butrans wouldn't help in this situation or other situations like this.
I've seen it kind of across the board. We use a lot of Butrans, probably in situations like you've shared, or if they have a lower OME need overall, but we think a long acting would be beneficial. I think my first population I really thought about it a lot was multiple myeloma, older, frail, tons of bony pain, likely some renal impairment. So a lot of those other comorbidities made that more attractive, or folks, as you know, who don't want to take IR opioids or just who want to like underdose themselves. You're just like set it and go. And we've had a lot of, I think we've had a lot of benefit with that. To your point as well, sometimes we'll push it above the FDA recommendation in this country. If it feels like it's working, we just want to push it a little bit more. But yeah, we might be throwing in the towel by 30, 40 if we're like, yeah, that, increasing the dose did not really benefit. I think it's a good medication, especially in patients with pain syndromes and ALS, right? Supposedly that ceiling effect on respiratory depression makes it perhaps your safest opioid in this population. We've used a lot of Belbuca, so like buccal, buprenorphine, and Suboxone. Feels like less successfully by the time they're pushing up to higher OMEs. I don't know that I feel like patients have loved us for putting them on Suboxone or buccal buprenorphine, or I guess buprenorphine in general as their mainstay.
Yeah, I'm using a lot of it too, both in ALS and for my patients with a lot of older adults with other illness going on. And I just find the results very variable, right? Like, sometimes we get a good response, sometimes there's like no pain benefit and somebody's very sleepy, especially an older adult, although many older adults really tolerate it. So I haven't figured out a rhyme or reason why sometimes it's more helpful than other times. But I do try it often.
Out of curiosity to the group, do you guys feel like there's a more consistent response for like very low dose, like, not that fentanyl is ever low dose, but a low, quote unquote, low dose fentanyl patch in patients once they're on a high enough OME? Like I've just seen the palliative group here at the Portland VA use fentanyl patches more often than bupe. I don't know if that's because it's easier to prescribe at the VA. I've never asked them. But the couple of patients I have who are on like the lowest possible fentanyl patches like do really well. Like they're like very, very well managed. And I haven't seen anyone kind of say like, I feel sleepy, but nothing's improved. But I haven't seen anyone come through in bupe patches.
Fentanyl patch, another 12 microgram per hour dose is definitely a higher dose opioid than a buprenorphine patch. So I have seen more benefit from that, but I usually don't reach for those first, only if someone's fairly opioid tolerant. But it's great that you've seen many people tolerate this well. And also, I've seen a lot of people benefit from methadone. So I kind of feel like since I've been using buprenorphine more, I've been using methadone less. But Cara, I think it was perfectly reasonable that you reached for methadone given the severity of the pain that this guy was having. I wouldn't have been surprised if the butrans patch wouldn't have been enough for him, and the methadone is more helpful. So you're still at a very low dose.
Yeah, and Farah just asked a question that I think is hitting on what I'm wondering too here. So yeah, the symptoms are definitely in his face. And I don't know the answer to this, but I would love to know from the group, do the symptoms in the face make small fiber neuropathy less likely? And then really like, would you push skin biopsy? Because I feel like I'm gonna use all of those neuropathic pain agents anyway.
I typically don't push for skin biopsy, at least in the kind of general neuromuscular clinic, because exactly what you mentioned, it's very hard to disprove a diagnosis of small fiber, especially if somebody has a little bit of dysautonomia and this and that. It's nice to have it. I mean, if it's thought to be an idiopathic small fiber neuropathy, there's 2 negative trials for IVIG anyway. So the treatment is primarily going to be neuropathic pain meds. So if the treatment pathway is going to be pretty similar, if you're calling it a central pain syndrome versus peripheral, then I don't think there's a ton of utility, other than if you find it a positive, then you can be like, well, for sure, at the very least, there is some component. Again, you can't exclude that there's also a component of central pain. So I find you kind of get stuck in this existential debate. So I typically actually don't, but I think it's kind of stylistic. My mentor at Sinai and neuromuscular biopsies everyone. We biopsy no one out here at OHSU. So I don't think there's necessarily consensus out there in neuromuscular world.
Thanks. So I think my next step with him is going to be to push the gabapentin. He's already on a little, so to try to get that dose up, and see where things go. But if anyone has a different path that they would take instead, I'd be curious. Interesting. And Catherine, have you seen it come on delayed?
Yes, yeah, particularly when people sometimes get ALS, then they kind of can't use their normal mechanisms for blocking the pain. And so then I've seen it come about. But if you feel like he has truly been off everything, no pain medication for years, and then it suddenly came on, yeah, that I haven't seen.
Okay. And no other conditions that would provoke neuropathy that we've found in him.
Cara, can you put his current medications back up? Can you put that slide back up?
Yes.
Yeah, I really appreciated your discussion, Kara, of the incidence of pain in ALS generally. And I've just wondered myself when I've seen people with ALS and severe neuropathic pain, like how likely it is that that neuropathic pain is related to the ALS or due to something else, whether we appreciate it or not, know what it is or not. And is this the same, ALS as someone else or who doesn't have the neuropathic pain, or is this somehow a variant of the illness that I, as a palliative care doctor, at least don't understand fully? But for those ALS specialists who are here, I'd love to hear your thoughts on that.
I mean, I've seen in patients who have familial ALS, I've definitely seen a pain syndrome, but more in the feet. I would say for the total body pain, I've not seen that in ALS unless someone has had a history of like alcohol or substance use. Just an increased I agree with what Monica wrote, just an increased sensitivity to pain.
Mm-hmm. Interesting. Mm-hmm.
Monica or others, have you found certain ways of approaching those kinds of patients with a lower threshold to be effective?
I think I found that, like you mentioned, so much of the pain is kind of this also added psychosocial distress element. And I find myself kind of toying with how much to escalate versus how much to just help support. I feel like for patients I've had like this with ALS or not ALS, I'm trying to reaching more for the buprenorphine and the neuropathic meds and things like the SNRI. But a lot of it is kind of the education piece. Like here we have a pain psychologist, like you mentioned that you referred this patient to psychiatry as well. So really to trying to kind of explore the pain, but I try to also share that even if the substance use was many years ago, I think it really, I don't have any studies on the tip of my tongue, but I believe there is a body of literature to kind of support that their wiring is different, right? The GABA has been kind of pounded upon for many years. And And that really does affect the way that pain perception and threshold are, you know, are experienced, I think. But no major breakthroughs in how to approach it.
Okay.
Just to recognize the phenomenon.
Thank you. Yeah, I think you touched on exactly the challenge with him, which is, do I escalate or do I approach with alternative modalities? And one, he has come to me in such agony saying, I might end my life. This is so horrible. And his brother actually successfully completed, he committed suicide. So he has that very high risk profile. And then, knowing that he is someone that will quickly reach for medications and could put himself at risk that way. So it's been a very kind of tricky situation.
Very tricky. And Cara, sorry, you said your plan. I apologize because I was pasting something in the chat, so I think I missed what you said, but you were planning to gradually uptitrate the methadone and the gabapentin, is that right?
Yeah, that's right.
Okay.
And to Farah's point, yeah, totally thought about if gabapentin up titration would probably be my next step, and then potentially rotation to Lyrica. And we have not re-imaged his brain. So he was imaged, at diagnosis years ago, but not since then. And have thought about it, but haven't pursued. He has talked about MAID and kind of for years, and says that he thinks he would eventually pursue, but his prognosis is multiple years. And Dan, in terms of percent of ALS patients with this kind of pain, it looks in the literature something like 10 to 30% have some type of burning pain, but I think something like this is exceedingly rare. And the reason I initially reached out to the group was no one around me had kind of seen this, and I think most of us on this call also haven't encountered someone saying they're kind of in agonizing pain. Very, very unusual.
Since we're all together, go right ahead, and I'll go next.
Oh, sorry.
No problem.
No, I was just gonna say, Carrie, I think your approach, it really kind of makes sense. Like you started with, a relatively modest dose of a nice long-acting opiate. I think that like being willing to reach for those, and as you guys kind of all mentioned, the buprenorphine, even though maybe you're not gonna push the buprenorphine to super high doses, I think that kind of builds bridges in some ways. Like, that's probably not the full answer to his pain because it's wrapped up in all these psychosocial pieces. And, but I think like you're sort of offering a bridge to the patient. You're saying like, I know you have this complex history. There are risks, but I'm not like that person who's like, whoa, 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 we can't do any more meds. I'm not going to treat you. But you're also like, you kind of already illustrated yourself. You said like, I can talk him off the ledge and then his pain goes down. So usually with stuff like this, sometimes I'm just very transparent with people. I just say like, I'm really worried about all these issues we're running into. I'm worried about, your history, your breathing, like how can we work together? I've often seen that like all of the medications in the world are not enough by themselves. Like what else can we do? How can we think outside of the box together? And I do sometimes just quote to people that we know these are not miracle drugs. Like I just tell people like the FDA threshold for approval for a neuropathic pain med is a 30% reduction. Like placebo by itself is often close to that. Like these are not miracle drugs and I know it. But I have seen people like have some effect, like they do get better. It can take 4 to 6 weeks for that to kick in. Let's give it a shot, And I think sometimes just acknowledging to people that the tools we have are very imperfect from a pharmacologic standpoint. Like a lot of our patients seem to appreciate that. I don't know if he would, but sometimes patients are like, oh my gosh, like, thanks for saying that. I feel like all my doctors just think I'm not trying. And like
Yeah,
just some
those are
thoughts.
great thoughts. And he's very, he's really a straight shooter and really appreciates direct communication. That will go over very well with him.
Yeah, I
And
imagine just having to corner, and maybe others too, but having people who are really attending to his pain, like truly caring, like willing to work with him, willing to try things in a reasonable and cautious a manner, probably means a lot. And through some of these early med trials, including maybe the duloxetine, you have gained a lot of trust. And then through that, trusting and supportive relationship that can have secondary, mood benefits, or just make him feel less alone and less lost with this difficult problem he's got on his plate. So yeah, all of this whole approach seems very reasonable. And I don't mean to distract the conversation, but if there's time, I'd love to just get people's thoughts about how you choose to manage fatigue in ALS also, because many people with ALS have a lot of profound fatigue. And sometimes I think about, should we reach for stimulants or not? And I'd love to hear how other people think about that in an evidence-free zone. There's not much data to lean on.
I mean, I do use stimulants in ALS, and I tend to find that most patients have a bit of a better response to Adderall, just subjectively feel like it does a bit more. But I love how kind of short acting Ritalin is, so that could be a nice option. And then for patients who get super fatigued by end of day, maybe try a long acting or just additional doses. But yeah, I certainly will prescribe it if fatigue is a big quality of life issue for patients and find it to be helpful. Oh, and sorry, I should say, I do caution about the weight loss, but I just haven't found it to be a big issue, and that they feel that their appetite is super suppressed from the stimulants in ALS.
I tend to
NIV, yeah.
I tend to reach for modafinil as my primary med. There's, one tiny study from 2009 in ALS that had some benefit. So I'm always still having to argue with the insurance companies that, given that it's not an approved indication, but I think I reach for that maybe because kind of like as we use it in, like for my cancer patients, I will reach for it if they're this is more of a long run situation, whereas I probably reach for Adderall later down the line. But it seems like it's been relatively well tolerated without too many adverse effects. I've had a couple people on it, but I don't know why I reach for that one before Adderall, but maybe it's because of this very small study.
And there are comments in the chat about using non-invasive ventilation as well for fatigue. Definitely seen that be helpful. Agreed.
I also tend to encourage it to be used as a very PRN, usage, and potentially not every day, and trying it just for sort of select experiences, and escalating only if needed.
A great reminder. I mean, as comment in the chat. Could I ask anyone for help remind me of the literature for high dose vitamin B12? I know a lot of my patients with ALS more recently asking for this or on it. And I think it's supposed to help with energy, but I'd love to learn more.
There were a couple articles that showed that it very significantly prolongs survival, like 50%. I mean, much better than Riluzole and Radicava, some of the recent literature. And so I think we've been prescribing it primarily for longevity to help slow the disease process, but I did not know that it helped fatigue. So that would be interesting.
Can you tell us what doses you're prescribing?
15,000 micrograms per day. They sell the 5,000 microgram dissolvable tablets at Costco, so it's just 3 a day.
And do you do that for everyone, Catherine? Or are you
I do,
screening
yeah.
certain? Okay.
Yeah, and I haven't had people have side effects or needed to stop taking it or anything.
Have you noticed a change in fatigue for people in addition?
I honestly have not paid attention, but we'll start to pay attention. Thank you
Cool.
for
It may
mentioning, and
be
I'll
that
look up those articles. I didn't know there were articles about using it in fatigue.
it may be that it's mostly helpful for fatigue in people who are vitamin B12 deficient. Might be the case.
Yeah, that could be.
I'm not sure.
Could be.
There used to be a lot of people who just got B12 shots like for energy. This used to be a thing. Maybe it's still a thing. I don't know. But I remember as a primary care doc when I was doing that of just patients who would kind of get them somewhere else. I didn't do it, but I think there was some sense that it's just, I don't know, somehow good for you without a lot of evidence.
You know, these would be really interesting questions to explore through kind of that rapid approach that I think I talked about previously, where we both the question about how to manage neuropathic pain in people with ALS, like what are we all using and what's working or what side effects are developing from treatments, and then also fatigue in ALS would be a really interesting question as well. So if anyone would like to take the lead on either of those projects, let us know. We could all collectively
Cara, I put
gather
this on my
data.
survey, but I think that just like being able to, publish articles on these topics even with the data that we get from a quick survey posted in the chat on these calls would be very representative, of so many different centers and people. So yeah, I think it's very exciting. I'm certainly happy to help with anything, neurological related around
Great.
putting together articles or surveys or whatever.
Fantastic. And for those who joined late, we put 2 surveys in the chat. One, if you'd like to give us feedback on this working group, we'd love to hear your opinions and move it in the direction that everyone wants to go in. And number 2, if you have an outpatient palliative care program that cares for people with ALS, we'd love to know about it for the directory. And then 3, stay tuned via email for a survey that we'd love to circulate to patients and caregivers who have ALS for the International Alliance on ALS and Motor Neuron Disease Association. So plenty of opportunities for surveys. Thank you for doing them.
Dan had a quick question in the chat, I think, about like if that's something that people just can start. Like, let's say I kind of on the flip side for you, Dan, of like let's say I see a patient, do I need to run it by their neurologist, for example, in terms of the B12, sorry.
It should be completely safe. I mean, excess is excreted through the urine, so I don't think you'd have to run it by anyone.
I would have to pass it by my nurse wife, hospice nurse. She would have some feelings about that, I'm sure.
I'm going to put a little bit of data of a summary that I just found online about this topic, vitamin B12 and ALS. Looks like there was a double-blind placebo-controlled trial in Japan, and it was of IM, vitamin B12, but over a 16-week period, showed some slowed progression of the ALS-FRSR. I don't see a lot about oral, but I can't claim to be an expert in this.
Yeah, I think that with the oral, there are several papers that talk about how if for most patients, the oral is absorbed equal to the to the injection, and that you can get the same equivalent level with taking oral as opposed to doing the injection, which can be quite painful and also expensive and hard to get. So that's why I've been using oral. But I haven't seen, you're right, the research has been more with injection, but at least I've been just referring to the papers that talk about the levels in the blood being the same.
It's interesting, as I have listened to my physician's talk, nobody's mentioned, the higher doses of B12 is that newer, or has it been around a while, or are there any studies that showed
Yeah, there've been a
good
few
results?
studies now, and so I think it's just increasing awareness. I think it just hasn't, they weren't big splashy papers, so I think maybe people aren't aware of them.
Awesome. Well, really rich discussion, Cara. We'd love an update if he benefits from the increased methadone or increased gabapentin or anything else, your ongoing support, etc. We'd love to hear about it. Hope to see many of you at INPCS next week. Maybe we'll gather Wednesday evening in some capacity, either at an INPCS happy hour or our own homegrown happy hour. That'd be really fun. And if you have a topic you'd like to discuss at a future working group meeting, let us know. We're always happy to discuss projects, cases, other topics, including the one you mentioned, Astrid, about fatigue management in ALS. That'd be great. So see you all next month. Take
Thanks
care.
so much for the discussion.